So first I'd like to invite Sylvia Asa. She's an endocrine pathologist who's taught us a lot about this disease at the molecular level from the University of Toronto. Sylvia.
Thank you. Thank you all. So it's impossible for me to tell you all about pathology of NETs in 10 minutes. And so I've decided not to do that. If I could have my slides, please. I want to just start with something very broad and general. And then I thought, most people don't know their pathologist. How many of you don't know the surgeon who operated on you? Not a single hand. How many of you don't know your oncologist? How many of you know your pathologist? A few in the room, yeah, and I recognize you all. Anyway, okay, so pathology is really, really important, and the problem with pathology is, as Dr. Pasieka told me, most pathologists don't want to talk to patients. And I feel very sorry for them because I went to medical school to be a doctor, and for me, patients matter. But I went into pathology because pathology really is the foundation of disease. We are the people who study what patients have wrong with them so that we can give you answers for what to do about it. Pathology comes from, actually that's not my first slide, let me go back. Pathology comes from two Greek words, pathos, which means suffering, and logia, which is study. So pathology is the study of suffering or disease. And what pathologists do extends all the way from looking at what's in your blood and in your urine to what's in your tissue. So every time you have a blood test, every time you give a urine sample to measure something like 5-HIAA, your sample goes to a lab that is run by pathologists who are responsible to make sure that the tests are being done properly. Now, most of those tests on body fluids are done by machines, and we ensure that machines and reagents work properly. So it's a very scientific, kind of technical field. But when we actually biopsy cells and tissues, or we look at stuff that surgeons cut out of you, that's done by people like me, where we actually look at the sample. We take those cells and those tissues, we look at them the way Dr. Gray showed you what a specimen looks like. A lot of surgeons don't always look at their specimens that carefully. They cut it out and then they give it to us. We look at it, we take pictures, we cut it up, and then we look at the interesting parts in the microscope. So at the end of the day, what the pathologist does is give you your diagnosis, which is the gold standard against which we measure everything else in medicine. Your pathology diagnosis is supposed to be the right answer. And all of the decisions that are made on your care are based on that diagnosis. What kind of disease do you have? Is it inflammatory or is it cancer? If it's cancer, what kind of cancer is it? We actually can do a lot of harm, but we can also do a lot of good. One mistake by a pathologist can be really bad for a patient. And I always say that, you know, you really only have two chances in life with two things. One is your surgeon and one is your pathologist. Because when we make mistakes, it's kind of like it's too late. Radiology, they can review it again, right? The oncologist, you get lots of opinions, there's time, you can go through all this stuff, but your surgeon blows it in the OR and you're dead, right? She doesn't need to say anything else.
You are now off the stage, okay? I think we've heard enough about pathology. Yeah.
Okay, so now that I've raised everybody's anxiety level, the important thing is your pathologist gives you a diagnosis. Your pathologist also gives you a prognosis, and you've already heard that. You heard about Ki-67, which you all know it's a word. Basically, this is one of the biomarkers that pathologists use to try and predict how fast is this thing going to grow? How likely is it going to hurt you in the next short while? And the other thing that we can do is we can predict what kind of treatment you need to have. We also can predict other things. We can predict genetic diseases. So I've already told you the scope of pathology is huge: biochemistry, hematology. If you get an infection postoperatively, we work in the labs to figure out what kind of bug you have and what antibiotic it's going to be sensitive to so that you can get the right treatment. We do the tissue diagnosis, that's what we call anatomical pathology, and now we also do molecular pathology. We take pieces of tissue or blood and we analyze the genetics to decide what mutation your tumor has or what blood disorder you have, like, for example, multiple endocrine neoplasia. gene so that we know that not only you, but your family may also be affected by your disease. So now normally pathologists get up and we show you pictures of slides, and I don't need to do that because our first speaker this morning, thank you, Dan, for being a pseudopathologist this morning, he showed you the pictures of what these tumors look like. And I don't want to do that again because I know that's very technical. What I really want to do is give you a few examples, and this will be short, but I'm going to give you a few examples of how pathology can change a patient's story. And the reason for this is coming back to what we were talking about before lunch, that pathology comes in different shapes and sizes. And in most hospitals, you have general pathologists who do everything from breast to lung to brain to you name it. And they're not really experts in everything that they see and do. And so we have moved much of pathology, I think, in some parts of Canada to a subspecialty model. And endocrine pathology is the orphan. Just like your disease is rare, endocrine pathologists are rare. I think there are only 2 of us in Canada, and we're both in the room here today. But we take this very seriously because we think we can offer you help that will be better than what you get from a general pathologist. So I want to tell you a few stories. This is a middle-aged woman who had a small bowel NET, and she was being surveyed postoperatively with 5-HIAA levels. That's something that's very familiar to a lot of you, right? So ultimately, she was identified as having liver lesions, but the diagnosis of metastatic NET seemed a bit incongruous because her 5-HIAA levels were perfectly normal. So, of course, the treating physician at that point said, there's something wrong, what's going on? And then we got a second review of her pathology, and this is a case I reviewed. And it identified that her primary tumor was not your ordinary NET of small bowel, because those of you who have had one of those know that they usually make serotonin, and serotonin gets metabolized to 5-HIAA, and we measure that to see if your tumor is growing or recurring. This woman had a tumor that was a paraganglioma, and it wasn't making serotonin at all. And finally, she had an answer as to why she'd been feeling anxious and flushing and had all these symptoms, and everybody was telling her that she was crazy because her 5-HIAA levels were normal. Well, lo and behold, her tumor was not making serotonin. It was making adrenaline. So they were measuring the wrong thing for 10 years. That's a problem, isn't it? So pathology matters. If we had done the pathology right from the get-go, we would have said, no, you got to measure adrenaline or noradrenaline levels, not 5-HIAA. So this is a really different story, right? The other thing is that paragangliomas tend to be familial, and small bowel tumors probably are not. So this has major implications for her family. So what we did was we did a special stain for one of the most common genes that's mutated in this disease, and it was negative, meaning that she actually had a genetic predisposition to this disease. So now we've changed, first of all, what her clinical symptoms are. She now understands that she's not crazy. A lot of people can relate to that in this room, can't they? She's not crazy. She actually did have hormone excess. Her diagnosis was actually wrong the first time, and she needs to have blood testing, as do her family members, brothers, sisters, kids, to make sure that they don't also have what she has. So completely different pathology. Here's another one, a young man with a lateral neck mass that was called a NET. Nobody knew where his primary was. Primary of unknown origin. How many of you have had that experience? I know I spoke to somebody before lunch. Primary of unknown origin. Well, you know what? Pathologists actually can tell you where it's coming from if we do our job right. So we actually went through the whole differential in his case. We stained his tumor for a whole bunch of markers, including thyroid hormone markers, lung markers, small bowel, all of those different kinds of markers. And guess what? His tumor was making somatostatin, which explained why he had some symptoms that, again, people said he was crazy. We also could show that it was from the pancreas because it had biomarkers of that. And we did a Ki-67 showing that it was a relatively high-grade tumor, so he needs chemotherapy, not some of the biologics that we were talking about today. Another case, another woman, this time she's got a thyroid lump, her biopsy's inconclusive. She has surgery to have her thyroid tumor removed. It comes out it's benign, but an endocrine pathologist looked at her thyroid and said, there's something else going on in the background here. I'm gonna do another stain. And sure enough, She had little tiny foci of C-cell hyperplasia in her thyroid, meaning that she has MEN type 2, and her family also can be affected, and we managed to get the other half of her thyroid out in time before she had metastatic thyroid cancer. So the spectrum of neuroendocrine tumors is everywhere, from thyroid to lung. Actually, pituitary should be included in that, parathyroids, pancreas, gut, all of these tumors. All of these need the right pathology to get the right answer. So another story, very short, abdominal mass in a man diagnosed as NET. They thought it was pancreas. He had a long ago history of a benign lung tumor. Another story that I know some of you have been through, and actually it turned out that that was his primary, it was a NET, and this was a metastasis. And now, I'm not going to talk about this too much because I think Dr. Ezzat's going to talk about this at the last talk of this session. Cell types in some tumors matter, and it helps us to predict prognosis and outcome. So you've all heard about multidisciplinary care teams. You, as patients, are at the center of every multidisciplinary care team, and you have lots of people taking care of you. Your family physician will refer you to all of these specialists. But at the end of the day, the pathologist who I've put at the very bottom of this picture is probably really important because Sir William Osler, who's a Canadian, said something in 1909. As is our pathology, so is our practice. What the pathologist thinks today, the physician does tomorrow. So make sure you know your pathologist and that you get the right diagnosis, prognosis, and prediction. Thank you.
Thank you very much, Sylvia, and also for staying on time. I'd next like to introduce Eric Liu, who is a thoracic surgeon, I believe, from, okay. Well, you don't have a bio, so I wasn't given a bio. So, okay, all right.
If this is a Holiday Inn, that would be okay.
All right. All right. So Eric, who we just met downstairs, is going to come and talk to us about lung neuroendocrine tumors. And he can introduce himself.
That was a very accurate, actually, introduction. I mean, I met you guys yesterday, right? You guys were all here yesterday, so I don't need to. So, okay, so I actually don't have any slides. You guys are probably all slided out. As of yesterday, I think I demonstrated my slide-making prowess, so I'm not going to dazzle you with slides. But I thought I can't do this in 10 minutes. Okay, I just can't. So what I'm going to do is, because just to let you know, last year we had a whole day symposium on nothing but lung. Right, and actually some of you came to Denver and saw that symposium. So I'm going to do something a little bit different. So my job is to talk about the treatment patterns, the treatment options for lung, which you actually have all seen today, right? So I don't have to tell you. Because the first therapy for neuroendocrine should be, right, cut it out, right. And the second therapy should be, right, and the third one should be, good. You see, you all remember my lecture from yesterday. This is very key and critical. Okay, so I thought we'd do a little exercise. If you, I've seen some of you in my clinic, but if you were to come, if you have, so to answer Dr. Pasieka's question, I'm actually a abdominal surgeon. I don't actually do that much thoracic surgery, except for my my neuroendocrine patients. And if you were to come see me, these are the kind of things that we would go through. So we would talk about your symptoms, right? And we try to figure things out. And one of the troubles with thoracic neuroendocrine disease is that they tend to go to the thoracic oncologist, right? And anyone in this room, you can hopefully validate this for me, but thoracic oncologists in general don't think much of neuroendocrine and carcinoid, right? Because they think it's a benign disease relative to what they're dealing with every day, right? They deal with these nasty lung cancers and small cell carcinomas. I mean, it's really pretty brutal what they go through each day. So I think they're really quite delighted. Oh, you have a carcinoid, get out, right? And so that's right. I think that would echo some of the experiences of some of the patients that they've gone through. So I really feel very strongly that seeing a neuroendocrine specialist is actually very important, and we encourage our neuroendocrine colleagues, at least in the States, to start seeing some of the lungs, and that's really been a challenge. Because most of the neuroendocrine specialists in America are GI oncologists, and so they don't feel quite so comfortable doing the lung stuff. And so I started doing it because I trained in Sweden, and so they did a whole bunch of lung neuroendocrine every single day. So it was just kind of the usual pattern. So despite the fact I'm not a certified lung surgeon, when we do this though, whenever we do chest surgery, I always do the operation with the thoracic surgeon, so that I can see what's going on and I can help and take care of the things, because there are always these little subtle things about neuroendocrine which the thoracic surgeon isn't so comfortable with. And only because I follow these patients for so long that you can get it. So after we talk about your symptoms, right, you get your history, you kind of figure things out. It's not uncommon for people to come see me after they've had their tumor removed, right? And so, and then we talk about how challenging that can be sometimes, because when the tumor is removed, frequently, unfortunately, because the thoracic people are not so used to neuroendocrine, they don't do all the imaging, they don't do all the tests, they don't do all the blood tests, right? So I see the heads shaking, because that's kind of what happens. And so I always tell people, if you can do all your homework before surgery, it's better than doing it after surgery, because despite the fact that, for example, the gallium scan I told you all about yesterday, right? It's wonderful and it's great. The problem is that if your tumor is gone, I can't take pictures of your tumor, right? And remember yesterday I showed you those pictures of the lung, in which the guy had a whole bunch of tumors and he was completely gallium negative. So I struggle sometimes, because if they have the tumor removed, I can't tell if, one, their tumor doesn't express the receptor, right, like I mentioned yesterday, or if they actually don't have any disease. So I always encourage people to do as much work as you possibly can before the operation. I hope that makes sense, and it's not rocket science. I told you yesterday, my wife told me I'm not that smart, so hopefully it makes sense. So then, but once you kind of get through all that, then it becomes, well, what do you do about it, right? So we know that surgery is always kind of the first thing we want to do. Why? So surgery does a lot of things. One, it gives the pathologist a ton of tissue to look at, right? Because taking a teeny tiny little aspirate and just kind of sucking a few cells out of a tumor is really probably the most challenging for the pathologist, because they don't have enough information, right? Even if you take a core biopsy, which is great, which is basically you take a tiny little chunk out of the tumor with a needle, they still will complain, right? Because there won't be enough tissue, and it's heterogeneous, and just because they sit behind the away from you guys doesn't mean they complain to me constantly. Okay, so you just understand how a pathologist really works. And so the surgery is actually very important. So you get a lot of information, right? And then the other thing too is when you do surgery, you can do it. There are two ways to do it. You can do it fully, or you can do it less fully. Let's just be frank about this, right? So sometimes when people are less familiar with it, they will take out a piece of lung or whatever it is, and they'll leave all the lymph nodes behind, right? So the reason I sit with my thoracic surgeon inside that person's chest is so we go digging after all those lymph nodes, because I've had to take care of too many patients in which they left a bunch of lymph nodes behind. And then we have to just sit and watch it, because a repeat thoracotomy is no fun, right? So anyone who's had their chest cracked open, and I know some of you in the room have had this before, you're never quite the same, right? It's a little bit like having the head of your pancreas removed. You're never quite the same. And so to go in there a second time, a third time, a fourth time is impossible. So we like to do things as much as we can up front. Then, after you get your surgery done, then it becomes an issue, right? Because now what do you do, right? And there are are some options. But as you heard from today, there aren't that many options, right? And especially ones that are studied, let's put it that way. All of our lung oncologists, they spend all of their time doing clinical trials in lung cancers, like really nasty lung cancers. And I'm glad they're doing that, because there are a lot of people dying of lung cancer. But when it comes to neuroendocrine, we don't have that much data. We don't have that many clinical trials. In fact, the Radiant-4 trial, which you heard about today and yesterday, is one of the first ones that really kind of brought lung into the forefront, which is really kind of sad, because lung is like 25 to 30% of all neuroendocrine cancers across the board, right? So there are a lot of people with lung neuroendocrine, and so you're lost a little bit. So what have people done traditionally? Well, traditionally, they've just taken whatever their chemos are from their lung cancer and just hit the neuroendocrines with it. And they just hit it with radiation, because that's what they're used to doing, right? And so we heard a statement today that neuroendocrine is not like the other cancers, right? It's not adenocarcinoma, that's what Dr. Gray said. And he's 100,000% correct. And so just to give you an example, I was seeing a patient from a small hospital on the Upper East Side of New York City. And she came down to see us. There are no small hospitals in the Upper East Side of New York City, just to make this clear, okay? So she comes down to see us, and I happen to have my professor from Sweden visiting, and she's 15. And so she gets her tumor removed. The Ki-67 comes back as 5%. 5%. So what did they decide to do? They wanted to give her cisplatin, etoposide, and radiation therapy. That's what they wanted to give her. Why? Because she was grade 2 with the Ki-67 at 5%. So now you see how challenging, how important the pathologist is, like critically important in guiding these things, and then how, decision making even in a brand name center may not be so perfect. We left that room. My professor, who's like 70, he thought that, he said, Eric, I think that's like malpractice, and we don't have malpractice in Sweden. So let me tell you, this is a big deal. So it was a real issue. And so the good thing is that at least we're getting some more tools that are coming along. The question is how to do it, when to do it. And the one thing I want to leave with you, and I hope you kind of pick this up, and hopefully you've heard it from all these people, is that neuroendocrine is a complicated disease. And it's complicated not only because there are 70 different flavors of it, like our ice cream, right? But the real reason is because there's an art to it, right? The art of neuroendocrine is not what to do. The art of neuroendocrine is when to do it, right? And that's really the thing. And so, it's amazing, all the different things and how people suffer and what we try to do to prevent things, right? So you heard about the lecture today in the surgery section when I said, when you heard, you want to do these things preventively to make sure people don't get problems in the future. And it's true. I've seen many, many times in which I wish I could have operated on this patient maybe 3 years ago because I would have prevented this disaster that I'm dealing with right now. So the timing of it is actually really critical, and it's no different for lung as well. So the good thing is that we can sometimes translate the various things that we have from our GI practices and the tools that we have for lung. And hopefully as lung becomes more and more prominent and you guys speak out and we talk and we advocate for you, that there will be a space for the lung people as well. Just to give you an example, in the United States, we have an annual big kind of patient conference. And for all the years they've been doing it, there was no talk about lung, zero, none. And it wasn't until the past couple of years that we started to advocate for lungs that we started to have special breakout sessions specifically for people with lung. So it's really important that if you're interested in lung neuroendocrine cancer, that you should definitely advocate, speak for it, and we'll do our best to talk for you too. Okay, so that's all I have, but we're not answering questions, right?
No, not
Okay, okay, I'll see you guys.
Well, thank you very much. And once again, Eric, thank you for staying on time. I now have the pleasure of introducing Dr. Cindy Card, who I have the pleasure of working with because she is one of our medical oncologists in our multidisciplinary clinic in Calgary. And the real advantage that Cindy brings to the table is that she's a medical oncologist that first was into lung and then neuroendocrine. So she brings both those expertise to the table when we discuss these patients. So we do have a thinking medical oncologist with us. So we decided that she should talk about pancreatic neuroendocrine tumors, and I'll leave it to Cindy.
Well, thank you so much for inviting me. It's my great pleasure to be here to talk to you about the treatment approach to pancreatic neuroendocrine tumors. As you know, we're very short on time, and so I know that you've already had a lot of talks about the different types of treatments, so I'm not going to spend time talking about how they work or what's the evidence behind, but instead what I wanted to do was take a patient of my own and walk through how we made the decisions we made for him. How do I advance?
So this advance, and that's your pointer.
Okay. So I think one of the hardest things for patients when they first meet me, regardless of what type cancer they have, is that there's not one recipe for everyone. And there's often this feeling that, my friend had cancer and they had this treatment first and then that, and that's how you should be treating me. And the reality is not only is there not one recipe for cancer, there's not one recipe for, a cancer like pNETs. So when I meet a patient for the first time, I explain to them that I'm a medical oncologist, so I'm a cancer doctor who treats with drugs we call chemotherapy, but I see my role first and foremost as a teacher, because I think the most important thing that I can do is teach them about their tumor, about what's happening to them, so that they can make the right decision for themselves. I always find it interesting when people say, well, if I were in their shoes, I would do this. And the reality is until you're in a person's shoes, you are that person making that decision, you don't have a clue what you're going to decide. And so I really want patients to be fully informed. So it's critical that I know about my patients before I even meet them. And so I do a lot of work before they even set the foot in the door. I review all of their reports. I go in great detail to see what their pathology is showing. Does their cancer look like it's going to behave badly? Is their Ki-67 going to be really high? And I'm going to be talking about chemotherapy with them off the bat. Do they have a huge burden of disease? In the reports, are there comments about the fact that they're unwell? These are all very important because I often have a plan before I even meet them, but it's never my final plan because really, once the person is in the room with me, that's when I know what I'm going to do, or at least what I'm going to offer, because it is the patient themselves who really help me decide how to approach their cancer. So when I meet somebody for the first time, I often make a snap judgment. I walk in the room and I look around, and if they have family members and I can't figure out who the patient is, I'm usually really happy, because that tells me that they're well. And that's huge, because how much a cancer is affecting a person does have an impact on how we treat them. And of course, I take a history and find out what sort of symptoms they're having. And then I find out more about them, like what do they do for fun? What is important to them? Because most patients, when they come to see me as a medical oncologist, have already been determined to have incurable cancer. So it's not very often that a patient comes to see me as the first physician or specialist where I'm going to see them and then treat them with curative intent. Fortunately, we have a good team in Calgary, and so the surgeons often have already seen the patient and have already made the determination if they're curable or not. So in most patients that I see, we're not talking about a cure. So I like to know what's important to somebody, because when we can't cure cancer, our number one goal is to make people live better and, of course, live longer. And a lot of times people say, well, when I ask them what they want, they say, well, make me live longer. And I always qualify that with that better. So what I was going to do is just use a case of this gentleman who I'm going to call Andy. It's not really his picture. And he's a gentleman who presented in June of 2013 with some abdominal pain and nausea. And initially was thought to have gallstones and had an ultrasound, and it showed multiple liver metastases. So went on to have a CT scan. There was a big pancreatic mass. It was wrapped around some major vessels. And he was actually sent to one of my GI oncologists first and was told, you have pancreas cancer. And I don't know if anybody here in the room with pNET have been told they had pancreas cancer and were informed that they had mere months. And what they didn't understand, of course, is that's not what he had, because when they went for the biopsy, it came back as a neuroendocrine, much to his relief. So he ended up being seen by our surgeons, who deemed him to be unresectable in his pancreas, but they were able to resect one lobe of his liver, because actually all the disease seemed to be confined to that one lobe. They started him on a somatostatin analog, even though he didn't have evidence of a secretory syndrome. He did have a high Ki-67, 15%, so he was grade 2. And there were some concerns about the fact that his disease might behave a bit more aggressively, so he got put on somatostatin analogs. I meet him in January. So this is June 2013 to January 2014 before I meet this guy. He looks great. Honestly, I couldn't pick him out of a waiting room as somebody who had cancer. He's feeling well. His imaging over the 6 months prior had shown complete stability of his pancreatic mass. And so in discussing with him what was important for him, really quality of life was number one. He understood that his disease was not going to go away, but that he was going to live with it and try and live as well as possible. And I really encourage people to try and do that. So we just continued with the somatostatin analog and followed him. About 14 months later, though, he came in. It was almost 2 years to the day that he first presented with abdominal pain, nausea, fatigue, and sure enough, the CT scan showed multiple liver metastases, and the pancreas mass was growing. So at that point, obviously we had to have a more intense discussion about what should we do now. Given the significant progression of disease, I'm not happy continuing with just the Somatostatin. We looked to see if surgery was possible, but the reality was that the pancreatic mass was still unresectable, and there were too many spots in the liver. We even looked at embolization as a possibility to try and reduce the tumor burden in the liver, but again, it seemed like too much was going on at once. So we needed to look at systemic treatments, and systemic treatments are drugs or any treatments that travel everywhere. Somatostatin analogs would be considered systemic. And so we have things like targeted therapies, so everolimus and sunitinib, and that's where we have probably the best evidence, or at least the strength of evidence. We have randomized phase 3 controlled trials telling us that these drugs, compared to placebo, delay the progression of cancer. But we don't tend to see a lot of shrinkage of tumors with these drugs. It tends to be stability. We have the PRRT, or the radionuclide treatments. This gentleman was octreotide avid, and so that was definitely something that we would think about. But once again, at this point, we didn't have the phase 3 study, and we still don't. I know it's small bowel. But in most of our experience with lutetium, for example, is that, again, you got stable disease. But for this man, I really wanted to shrink his tumor because he was having a lot of symptoms. It was rapidly progressing. And so we actually talked about chemotherapy. Now, chemotherapy doesn't get discussed much with neuroendocrine tumors. The old drugs that we used to use, streptozotocin-based protocols, here in Canada, those drugs are really hard to access. There are lots of phase 2 trials with temozolomide-based chemotherapy. And in different provinces, you guys have different access to these sorts of drugs. In Alberta, fortunately, we do have it. So I decided, and discussing with him, with all the options available to us, he was, that he had cancer that was growing very fast, faster than I would have anticipated. His Ki-67 initially was 15%, and he had a rapid onset of his symptoms due to this diffuse liver involvement. And so we went on and gave him chemo, and he got capecitabine and temozolomide. Within 4 weeks, we knew it was working. He was no longer having pain, which was a huge thing for him. And 2 months into it, CT scan showed a dramatic decrease in the size of his tumors, including in the pancreas and in his liver. At 8 months into it, his tumors were still shrinking, and he was feeling great. Other than a bit of fatigue, he was tolerating the chemo very well. Capecitabine, temozolomide are pills, so that's really convenient for patients. And at 11 months into it, his CT now was stable compared to the 8-month one. And he decided that he wanted to get back to what his love was, which was sailing. And so in May of last year, May 2016, he decided that I'm going to take a break from chemo. I'm going to continue with my Somatostatin, and I'm going to take the summer off and go and enjoy myself on my boat. Luckily, I saw him just a few weeks ago, as CT still shows no evidence of disease progression over the last year. His chromogranin A has stayed down. He feels great, and he's now thinking about going back to work because he's bored. So this just illustrates one case. Everybody's different, and so I think what I'm trying to get at is, as you can see, as we went along, he was involved in the decision-making at every point. And a lot of what I decided to do was based on what he needed. And so, yeah, that's it. Thank you.
Thank you very much. Cindy's winning the contest so far because she finished in less than 10 minutes. So she was practicing upstairs, I know, in her room. So I have the distinct pleasure of introducing a friend of mine who I've known through this association and neuroendocrine tumors we talk a lot about because Danny Rayson, a medical oncologist from Halifax, has had an interest in this disease for as long as I have in surgery. And although we see things from a slightly different perspective, we've always been on the same page. So, Danny?
Thanks very much, Janice. So you can see I put 10 minutes in the title, so I have to stay on time. And Dan, I'll be staring right at you, I promise. You've heard a lot about GI neuroendocrine tumors, and I'll try to keep the overlap down to a dull roar, but some of the things, there's some constant themes, which hopefully, in the end of the day, will stick the more times you've heard it. In oncology, especially when surgical cure is not possible, we always have to think that the treatment shouldn't be worse than the disease, right? It's a key principle across all cancers. And as Dr. Carr just said, in the metastatic situation, our ultimate goal is prolongation of not just life, but good quality life, right? And how do we do that? What we're trying to do is minimize the suffering, complications, and problems that come with progressive disease, but we also have to make sure that we minimize the suffering, complications, and problems that come with treatment, right? And to try and find that balance for every single patient that we see. So if you look at this little cartoon I'm just going to show you, if you look at the blue line, as you start on the bottom, that's no treatment, no nothing, and the chance of actually controlling a tumor that's growing is 0. But as you add treatment, we hope that the chance of tumor response or stability starts increasing. But we also know that the more treatment you add and the more often you do treatments, again, if you do none, if you look at the green line, there's no side effects. But the longer you go and the more you treat, the side effects start climbing. And at some point, those two lines cross over, and the side effects might be worse than the disease. And for every patient in this room, that timing and those lines cross at different points based on factors that mostly we don't understand. Okay, so that's why, again, not one treatment for every disease. All types of rhythms to these treatments are potentially feasible and reasonable depending on the situation, which again makes it very confusing when you're trying to sort out what's best for yourself. And at some point, as the side effects keep growing, the treatment effectiveness starts dropping off. And I think one of the surgeons said that we do a great job sometimes beating up patients, and it's because of some of the things we do. So in terms of GI NETs, so these are neuroendocrine tumors of the intestinal system, there are really a few unique factors that help us decide who needs treatment and when. The first is the rate of clinically relevant tumor progression. And I say that very slowly and with all due respect to our radiologists, because as you know, many of these tumors grow very slowly, and the body can take a 1 to 2 millimeter change every 6 months for a very long time without it ever affecting the patient. So progression is not always clinically relevant progression, and we have to be careful not to jump on everything as a critical phase in treatment. The presence or absence of functional syndrome. So again, as you have heard many times today, 30 to 40, maybe as high as 50% of patients with neuroendocrine tumors of the intestinal tract that metastasize disease to the liver eventually develop a carcinoid syndrome with flushing or diarrhea, which really greatly affects quality of life and really mandates treatment essentially as soon as someone comes to that diagnosis. And then with PRRT, increasingly being accessible across Canada, as you've heard, slowly but surely, does the tumor express somatostatin receptors? So those three elements guide a lot of our thought processes in terms of selecting treatments for individual patients, but also trying to figure out what the right timing is in terms of the treatments we might have to offer. And then we have questions at each time point, and this is true for NETs of the pancreas and NETs of many other parts of the body. Does this patient need any treatment at this time? And many times the answer is not necessarily. Is the change on the scan significant enough to pose a threat to the patient so that we need to change or start treatment? That's different for every single case we see. Is there something we can do to target the specific area of disease? So again, as you know, a big focus of disease in the metastatic situation for GI NETs is the liver. And as you've heard, there are lots of different treatments we can offer that target the specifics of the liver, but try and leave the rest of the body untouched with some of our medical treatments. And is there surgical options? Always, always, always. So this morning I ran through a couple of scenarios, and just from neuroendocrine tumors of GI tract, again, there are 4 key ones. One is the local problem of that shaggy mass you saw pictures of in the mesentery or the saran wrap of the bowel that slowly grows and grabs bowel into itself and causes obstruction. So that's one big problem. The second, of course, is the fact that it affects the liver in the majority of cases of metastatic disease. The third are the hormonal syndromes. And the fourth are the cardiac issues, the cardiac valve issues that can happen if the hormonal syndrome is not properly controlled. Okay, so every patient we see, we should be going through each of these 4 syndromes in our head as oncologists and trying to figure out where this patient is at this particular time, and is there something specific we can do about 1, 2, 3, or 4. So you all know about somatostatin analogs, and it is our first-line therapy due to a number of factors. One, data suggesting that it does prolong stability compared to placebo, but also the tolerance of the treatment, because remember, part of the goal is to minimize side effects, and the fact there's some great patient support programs, which I'll talk to you about in a minute. There are 2 options. The one we've used for decades, Sandostatin LAR, and I think many of you are very familiar with this one, given once a month, typically. And the second, a sort of a newer agent called Somatuline Autogel, also given once a month. The difference between the two, Sandostatin is given as a deep injection in the muscle. The newer one, Somatuline, is given as a shorter injection in the tissue of the bum. So there are some advantages potentially for that. Plus, the Somatuline patients can be taught to self-administer, or families can self-administer. So it's just a new potential option for patients as first-line therapy with a different treatment profile. Again, both of these agents are incredibly helpful for patients with carcinoid syndrome. We've talked about the flushing, and we haven't talked too much today about the diarrhea that comes with carcinoid syndrome. And if you just look at this quick graph, this is what happens when a patient comes off their somatostatin analog with carcinoid syndrome in terms of bowel movements per day. And this is what happens when you resume the somatostatin analog. So somatostatin analogs can be incredibly helpful at controlling the hormonal syndromes that arise, particularly for GI neuroendocrine tumors. But it's also important to note that serotonin, which is a key driver of the problem, is not the only hormone or peptide that's produced by these tumors. And so somatostatin analogs may be not as helpful for patients with tumors that secrete other types of peptides. Now, I'm not going to belabor this. I promise you there's only two slides with these lines, okay? I promise. This is data from the most recent Somatuline study, the large study looking at the newer somatostatin analog. And the key element that I think is important is that on the placebo arm, progression-free, about 50% of patients did not have disease progression after 18 months. And 90% of the patients who went on this study did not have progressive disease to start with, which just gives you a sense of the time frame at which the natural history of these tumors might be wired to just sit there, okay? So again, just the point is not everybody needs treatment right away all the time. I'm just going to skip this last one. Now, like a lot of our treatments in oncology, nothing is cheap anymore. And this is, again, an issue, the elephant in the room that we haven't talked about in terms of access. We're very lucky. I put on my best Boston accent and called a pharmacy in Boston to get the cost of both these agents in the States versus Costco. So not Costco US, Costco Canada. And these were the differences. So about $4,300, $4,500 to $5,400 US versus $2,500 Canadian Canada. So we still are at a significant discount, but even so, these prices are way out of reach for almost everybody every month. And thankfully, both these products have excellent patient support programs that even if you don't have insurance coverage, typically will provide full support. So it's very important. If anyone's paying for this stuff out of pocket, there are lots of patient support programs to help, okay? And you should be very proactive in getting yourself enrolled on one of these. Last couple of minutes. So do I have 2 minutes?
No.
Okay.
20 seconds.
I don't have it. Okay. So what's next if disease progresses? So we can increase the dose of the somatostatin analog. We can add everolimus. If we have access and the patient has octreotide avid disease, there's PRT.
We've talked about surgery, radiofrequency ablation, embolization, and this new chemotherapy that Dr. Card mentioned, which I think most of us practicing over the past year are increasingly using for patients with progressive disease, both because of efficacy and incredibly well tolerance. So I'm done. Just to let you know, before Dr. Pasieka hooks me off, we do have Canadian consensus guidelines that have been published that are largely due to the collaborative work we've all been doing in this disease for reference, and thanks very much.
All right, not bad. But it's going to fall on our next speaker. If he can come under time, then I'm taking the moderator's prerogative and we will allow for 2 questions. If he goes over, there will be no questions. So I do have
Taking the introduction away so I can add time.
Yeah. I have the pleasure of introducing Shereen Ezzat. He has another uniqueness to the treatment of neuroendocrine tumors that I have certainly learned a lot from him, and that is that he's an endocrinology oncologist. So he brings 2 different aspects of this disease to the table, and he's going to talk about the treatment approach to rectal NETs.
Thank you, Janice. All right, all kidding aside, I'm not going to be as philosophical as Dan. There's no philosophy here. This is the end, literally. You actually heard something from Eric, and he is an MD, by the way. I did meet him once. We were in a bar. He did tell you that lung was on the rise, and he's right. It's about 20-25% of NETs. The second largest, actually, in terms of numbers now is rectal, which is something that I have to play a very hard time convincing my medical oncology colleagues, because a lot of them don't see rectals. It's often sort of a bit of a different area, and as a result, they're seen by very different groups of specialists and really causes a lot of difficulty. So I'm going to call this disease too much, too little, too late. You'll understand why in a minute. So let's see how common they are. Well, it's actually about 1 per 100,000 clinically, and these are usually less than a centimeter. And the easiest and the best way to sort of look at it is that size matters, okay? Atypia, meaning that the histopathology is of importance, what the grade is, so you've already heard about the G1, G2, so I'm not going to bore you with that. But one of the most important aspects is the depth of invasion, and this is a very critical thing. How deep in the bowel wall does it go? And that sometimes is very difficult to ascertain because of the type of biopsy that's obtained. If a sample is not cut properly, then you can't really tell how far it has penetrated. So the quality of a specimen and how it was obtained is going to be absolutely crucial. This is a very, very important area. It's also an area where there's a lot of, and I'm not a surgeon by any stretch of imagination, but I understand there's an awful lot of advances in robotics and other technologies where device-assisted endoscopic mucosal resections, endosubmucosal resections, there's all sorts of other stuff really basically to preserve anal function. Am I almost correct? Oh. So it's an area where really oncology is going to have, I believe, a tremendous impact on preserving bowel and anal function in many of these patients, most importantly in making sure that those who need aggressive therapy are able to receive it, and most importantly is to avoid aggressive therapy for those who don't. In order to do this, you need to know a lot more about that. So here's my slide just to show you in green that the rectals are on the rise, and these are clinical, and this is not just a function of scans, because these do not get picked up on scans. They actually get picked up typically at a time of a colonoscopy, a procedure that you'll see in a second impacts. So one of the most important things that I'm really interested in, even as a clinician, is to be able to understand how we can really predict not just how well a tumor is going to behave. In my view, that's actually too late. What we really don't spend enough time on is how can we identify those who are at risk of developing the tumor in the first place. And that's the reason why germline, not tumor, but germline. So your blood, your DNA, your entire DNA can be assessed to determine why some people, such as Asians, for example, have the highest increases in rectal NETs, which is not the case in Caucasian populations. And these are the germline. And this slide just basically shows you the results of an international consortium that I belong to with Andre Califano, who's the head in Columbia and New York. And really what it does show are different genetic and epigenetic events. You don't need to really look at each of the triangles other than simply to appreciate that pancreatic neuroendocrine tumors are very different from small bowel, very different from colorectal tumors. But most importantly, if you start to actually look at these genes, the important thing is that many of these genes are potentially changes not in the gene itself, but in genes that control other genes that respond to external stimuli. So really the clue here is that there is something in our diet, there's something in our environment that's actually able to impose on our genetic makeup that makes us vulnerable, and interestingly, therefore, it makes sense that the lung and the rectum, both exposed to the environment, are showing the greatest increases in incidence. So the typical thing here that we need to do is identify who's at risk. And certainly in Canada, I think this would be a tremendous opportunity to be able to do something very different, very unique, and very purposeful compared to what we've been doing so far. This is just simply to show you specific chromosomes and specific abnormalities of gain and losses, again, in colorectal versus other types of neuroendocrine tumors. Very different. It also depends on how you actually detect them. This is a study that comes out of Korea where they actually looked at 21,000 colonoscopies. That's a lot. And of these, they identified 180 patients that had 180 rectal nets. They followed about 150 of them for a period of time to identify that really, by and large, most of them do well. But what they wanted to ask was, what were some of the clinical predispositions? If we don't know the genetics, what else can we make up of this? And the interesting thing is the highest likelihood of why you're going to get a rectal net is having had just cancer in general. Again, identifying that there is some level of genomic instability. There's vulnerability to some individuals of developing these cancers. The other is that if you have too much fat in your diet, and if you have too much triglycerides, that's also a risk factor. And if you are fat and you're insulin resistant and your blood sugar is going up, you're also at increased risk of developing this disorder. Again, identifying that what we eat and what we do and what we get exposed to is probably a risk factor, something we need to consider. Further detections, unfortunately, we don't have this in Canada. We do gallium-68 combined PET with CT, but in other parts of the world, including Europe, and Raj from King's College lent me this slide, where they actually routinely, for their rectal nets, do gallium PET with MRI. So they can look at the nodes and they can look at the depth of mucosal penetration before they actually do their endoscopic procedures, which I think is really the way to go. So defining the risk factors, again, you're going to be in a good category if your tumor is less than a centimeter, well-differentiated, low Ki-67, no lymph nodes, which means you got to know whether the lymph nodes were actually sampled and looked for or not, just like you heard with lung, as Eric told you. So again, very good parallels between the two. The high-risk patients are the ones where obviously much more technically advanced type of procedures are going to be required. And I think that's going to be the critical task here. Who do we pull out from that large group of patients to know that they're going to be in trouble so that we can actually do something about it before they come back? And typically they'll have an abdomen full of lymph nodes, and typically they're retroperitoneal lymph nodes, and we don't have very good therapy. If you thought that chemotherapy was typically not very effective, it's even worse with rectal nets. So that's why it's very important. This is just another example of a laparoscopic procedure, but I wanted to show you something else, which a lot of oncologists actually don't even really appreciate. So I hope that maybe we can discuss this a little bit more. And that is the so-called cell type in the rectal net. And what this slide is actually showing you is a 5 and 10-year survival. And basically it's showing that the G1, G2, and G3 again applies, the size also, and the lymph nodes in each of these panels. But look in the bottom right-hand corner. If you have an L cell type, chances are you're actually going to do very well. Your 5 and 10-year survival are pretty good. Whereas if it's non-L cell type, your survival goes down by half. Half. Much better than the difference between a G1 and G2. And I dare say that there are very few labs, certainly in Canada, that actually characterize the rectal nets, because most clinicians don't ask for it, and if they don't ask for it, they don't do it. This is just to show you again that these L cell markers go along and correlate with the grade of a tumor, the size of a tumor, as well as the presence of lymph node metastases. And overall, even when you adjust for other factors, yes, you actually will come up with the importance, again, that the cell type, so it's not just a matter of size, but the quality of the rectal net is very important. L is good, non-L cell type not being very good, and it's very, very important to make that distinction. I'm just going to end with this, 2 slides actually. One is in terms of diagnosis, so it's very important to know what you're dealing with, just like every other area of neuroendocrine tumors. You've got to know what you're going to plan for that patient after you've dealt with them, not before, so that you have a very organized treatment plan, which includes assessing the size of a tumor, the depth of penetration, the cell type. All of this figures into what you're going to do in terms of extent of procedure and whether this is going to be a minimally invasive versus a much more radical or somewhere in between. But more importantly, the other aspect is how do we actually follow up these patients? And my experience has been so many patients who end up getting followed with the wrong test at the wrong frequency until they come back with a disaster. So we have lots of patients who are getting tests that they don't need, and those that do, don't. Too little, too much, too late. Thank you very much.
Absolutely. All right. We have a new winner. And with that, I think we can open it up for a couple of questions from the audience. You've got this incredible panel here. Yes, the lady at the back here. That's you. Yeah.
Nope.
No. There you go.
That's better? Okay. So, yeah, serotonin is a classic one, the one that's clearly related to the flushing and diarrhea. But some patients present with wheezing, spasm of the airways that might be due to histamine or something called kallikrein. And there are a whole bunch of others as well, which we don't generally test for. So many times, and we heard a case this morning of someone who had, our patient who shared her incredible story, who had this pounding heart rate, and one wonders if there was a different type of hormone secreted by her tumor in addition to perhaps serotonin. So there are other peptides that are secreted. Many times we don't test for them routinely at all. Many times we don't think of them, and they can be associated with other sort of non-carcinoid syndrome, but definite symptoms.
Any other questions from the audience? Yes. Yes, Shereen. Yep.
Okay.
So the question is, how do you
Thank
get
you for,
brought to
yeah,
a
we
tumor
actually,
board?
We kind of, I helped him plant that question on, so thank you. Conflict of interest, I'll declare it. I get paid a tremendous amount of money for being the chair of a provincial tumor board. Again, another conflict of interest. It's actually that much. In fact, we're not allowed to buy cookies for the tumor board. But that's another story. What we have done in Ontario, and I'm interested actually in knowing what you guys do is, and it was largely based on a specific effort related to the utilization of peptide radioreceptor therapy. So Cancer Care Ontario basically empowered us to sit down together, stop fighting, stop bickering, stop complaining, and sit down and try and work together. And we do this by means of video conferencing once a month, where everybody who has a patient with a neuroendocrine tumor that they want to present to the rest of the group. It was primarily intended to be able to determine 2 things. Number one is how best to manage the patient in general, because as you heard from Eric, for instance, if you happen to be a GI oncologist, you probably don't know much about lung nets. And the right thing to do is to be able to say, let me go to my colleagues actually who deal with this on a day-to-day basis. So what you want as a patient is to be able to say, please, would you mind letting me know when you're presenting my case to the provincial tumor board? It's a very simple question. In that, we also recognize that there will be some deficiencies, so we actually will tell that physician you might consider more testing, more reviews of the pathology or the imaging, consider additional surgical procedures. Maybe this patient could benefit from an additional type of investigation that could influence what the next step is going to be. And ultimately, we come back with a recommendation where the patient could be triaged to go to another center where they have access to that diagnostic or therapeutic test that's not available in that home site.
I think that sort of across the country, there is now more and more of these focused, multidisciplinary clinics. Vancouver, Edmonton, Calgary, Winnipeg, people that just Halifax, several in Ontario. And so there are across the province, across the country. And so you just have to ask and it gets referred. And in Alberta, we just went on the road and Dr. Ruther, Dr. Card, myself, just educating our other physicians. And they have no hesitation of then sending it, getting an opinion, we then send back the information. So I think it's important to recognize that if it's not quite in your province, it's in the province next, and we don't mind looking at it. Danny?
And I'll just add one thing, being from Atlantic Canada, where we can buy our own cookies in Atlantic Canada. Just, we didn't need the government to tell us to do this. But so we're centered in Halifax, of course, but many of our patients, our referred patients, come from New Brunswick, Prince Edward Island, and we telehealth and video link all the time. Just agreeing with Janice that even though if you're not perhaps in the major urban center, there are always opportunities to have multidisciplinary input in your care.
I said only 2. I don't like odd numbers. I'm going to let you, if it's very quick, I'll let you do it, but it's an odd number, and that sort of gets me anxious. Okay, we're going to go for 4. We're going to go for 4. All right, first, second. Who did you vote for?
Healthcare is provincial.
Sorry, did somebody else on the panel want to answer that one? So why are we so different from provincial?
But yet you can still video conference each other and refer to each other. It makes.
Let me just be clear. Okay, hang on, guys. But let me just be clear. I don't want you to misunderstand the type of collegial interactions that sometimes occurs, and sometimes we do that. But that's a little bit different than actually what I was talking about that actually Ontario imposed on us. They imposed on us essentially a plan whereby the patient cannot receive a specific therapy until they go through this process. So this is creating sort of a paradigm that's a little bit different. Before, we did it because we wanted to be collegial. We wanted to sort of help each other out. And I'm not suggesting we don't want to do that. But what I'm saying is that in the interest of trying to identify and monitor the quality of care, that's the pretext, but also recognizing that resources are limited, the government is trying to create a paradigm where there is some ongoing monitoring as to how we're going to balance the demand and the supply here. And I actually think, recognizing that this is always going to be a challenge, we need to be actively participating in how these metrics are going to be imposed. And this is one way of doing it.
Okay.
Always move to America.
Not an option. Not an option. We have one more.
It's huge there. It's really huge.
Huge. Yeah. One more.
Same thing.
Same thing. Midgut, small bowel, yes. One is from an embryological definition and the other's an anatomical. So when we say those, they're synonymous.
So just to add, and you've heard me say this many times before, I think all those terms should be thrown out. Is a neuroendocrine tumor of blank origin.
Cell
Appendix,
type.
small bowel,
Cell
lung.
type. No.
'Cause
Cell type.
well,
As
then-
Dr.
then you
Ezzat
have to
just
be
pointed
really-
out.
So I'd like to end this panel before the panel starts to fight. And
should've
thank you
stopped at
very
3,
much.
Jen.
And the panel.